Okay, we're live.
Okay, thank you very much. Good afternoon, night, evening, and welcome to the second version of the Insurance and Pharmaceuticals Subcommittee meeting today. Because of the truncated time that we had this morning between session and hearings, we were limited in what we could achieve. Hoping that we will be efficient but thorough this afternoon. We're going to work until 6 and then assess where we are in terms of working through the agenda that was sent out. We are going to hold House Bill 912, so that is one that we can take off our agenda for the day. We're going to start with House Bill 413, which is health insurance individual market stabilization, extension of provider fee. And I'm just going to start off by saying we had a lengthy discussion about this morning. We understand that there are concerns about this being a tax assessed on carriers that is ultimately passed through premiums. We understand that that is an issue. We understand that the carriers are interested in looking at a variety of ways of funding this, and that would appreciate more time to before we jump into just reinstating the current program. On the other hand, we heard this morning from the Insurance Administration and from the Health Exchange and about how important this program is. Everybody wants this program. I just want to be clear. Everyone wants the program. And that it has done what it was intended to do, which is keep premiums down and get more people into the insurance pool. We have more people insured in Maryland now than we did 4 years ago before we had this program. So, and I want to say, passing this bill, passing 413, does not prevent us from making changes and adjustments as we go forward. So what it does is it gives us comfort if we don't, as we move forward, knowing that if the waiver is approved, we'll be able to sustain the program. So with that kind of opening and not relitigating those particular issues, if you have another concern or issue that I did not just speak to, raise your hand. Delegate Morgan.
I just have a question on that, because if we have a surplus right now and it's over the surplus amount where we originally intended and the program is lowered rates, and why are we continuing to just add more money to that surplus? I mean, if we can get back and make adjustments later, like we're saying that we can, I just have this whole theory that excess government money laying around gets spent on things that we didn't intend.
Well, and I share that concern as well, Delegate, which is why the guardrails are in this bill, preventing any surplus from being used for anything other than the reinsurance program, except the ones that we have already put in place. The young adult subsidies program is already in place, and so the bill says, we funded that, I think, for 5 years. We're going to continue to fund that. But I think, the answer to your question, and I'm going to probably say it in simpler terms than Brad Boban did this morning, is simply the federal funding isn't reliable. It might be, we don't know. And what he said was that the program costs about $400 million a year. And so, that cost could potentially go up. It could potentially go down. So that's why we're reporting on this every year. That's why we're analyzing it every year. But if we can make sure, like I said, if we can pass this bill to give us comfort, knowing that we can move forward and feel like that program is going to continue, that's what we're trying to do here. Delegate Saab.
Thank you, Madam Chairman. So I'm just trying to figure out one thing, and I know it's been mentioned before. Who is really paying for this? Is it the insurance companies paying for it, or are they passing it down to the member?
They're passing it. they're passing it down to the member.
So the
That's-
members are paying for it.
The
throughout
members are
entire
paying
state.
for it. I'm sorry to interrupt you, Delegate.
Sorry, go
The
ahead.
members are paying for it, but there is a benefit to them. You know, like their level of insurance, should something catastrophic happen to them, is dramatically increased by our reinsurance program. They can rest assured that if, you know, like I said, a catastrophic event happens in someone's life, they're not going to be responsible for more than they can pay because the insurance carrier was not able to pay it. So yes, it's one of the things we pay for, but there's a benefit to it. And the other benefit, that's the benefit to the individual. The benefit to the market is by keeping insurance rates down, everybody benefits from that.
No, I realize that. So when you say the member, and just for clarification, so is it the entire pool of the whole entire umbrella is paying for it, or is it just the members in that market? Is it
It's-
everyone that's insured in the entire state of Maryland paying that fee?
No, it does not apply to the self-insured funds. And Commissioner, I'm going to look to you and ask, is it beyond it's certainly the fully insured market, and we heard this morning it was also the small group market.
The 50% of the assessment comes on average from MCOs.
And MCOs, right?
They pay about 50%, 75% of percentage of that comes from federal dollars. The other 50
75%?
comes from federal dollars on average.
Okay,
The other 50% that is spread across private insurance is across individual, small group, and large group. To give you an idea, 13% of the entire 100% comes from small group. So that's about $16 million based on $1.6 billion of premium volume.
does that help,
Okay.
Delegate?
Right, so basically everyone in the state of Maryland that is technically insured has to pay for it one way or the other.
Except those who are covered by the self-insured market, yes.
Right. Okay, thank you.
Other questions?
Hold on, just to piggyback on that, I want to make sure I understand, if that's okay.
Sure.
So, I mean, if you're on Medicaid, Medicare, if you're self-insured, you're not paying into this, right? If you're on the VA system, there's a bunch of different ways you can have insurance in Maryland, and you're not being taxed, right? It's only for small group, large group.
And individuals in the fully insured commercial market.
But if you're in the individual market, you're the one receiving the benefit, correct?
Correct.
Okay, but you're not paying it. They're not the ones getting the 1% tax. It's the insurance companies they're in a small group market that are paying this.
The individual market does pay the 1% tax too. All
Right.
fully insured. It's a broad-based tax on all fully insured business in all market segments. It's only self-insured that does not pay the tax.
And by self-insured, those are the big organizations like,
So self-insured and Medicaid and Medicare.
right. Well, not Medicare is federal, so take that out
Medicare-
completely.
Well, they still have insurance. They're not paying into
Right,
it.
yeah,
Medicaid does pay.
right.
Yes. Medicaid does
pay.
pay. Medicare does not pay. VA does
Right.
not pay. Federal Employee Benefit Program does not pay. But Medicaid is a state program and Medicaid pays, but the federal programs do not pay.
Okay, thank you.
Delegate Krebs.
Madam Chair, it's so frustrating listening to this. We got to make it simple. Right now, no one pays except 17% of the market that's actually a payer. Medicaid is state government paying it. So those people don't pay anything. So we have 17% of individuals or small group paying for all of this. Part of that's MCOs, part of it's just fully insured, but the rest of the pie, the Medicaid, the Medicare, the self-insured, the federal employees and the military, which is the rest of the 70-some%, 80-some% of the market, doesn't pay any of it. So just look at your chart that has been given to us over the years of who we're affecting. It's 17% of the market, and Medicaid, which is Medicaid people don't pay anything. The state of Maryland and the federal government pay it. So, I just wish this is one of these issues that our committee does a really good job of trying to understand things and work things out in the interim. This is one, I guess, because of COVID, we haven't had time to really look at this program that we put in place a few years ago that we all agreed was a temporary fix. And the temporary fix was, and I pulled my files from 3 years ago, and it was sold to us as a temporary thing that was going to make people get into the market, and all these people were going to get in, and prices were going to go down, more people being short, and we wouldn't need it anymore. And we would find another funding source. And here we are in front of us today saying, oh, this is the easy way to do it. And everybody's sold on it. And I'm disappointed. I'm going to just say it out loud. I'm disappointed in the administration for not finding a better funding source. This is a simple way to continue this tax on these very small group of people. And we have not really looked at a better way of doing business. And the other thing we haven't looked at, did we ever get any good health outcomes out of this? The MCOs do a very good job with health outcomes. The rest of the market, we don't even know, because we haven't looked at any of it. So I'm just saying it's frustrating. The more I understand it, the more frustrated I get. But saying that, I'm just going to vote against it. But I hope the committee, I will not be here. I hope the committee really looks at this and at the fairness issue and what the outcomes so that when we all bought into this program a few years ago, what it was supposed to do. And that's not what we're doing here today.
Thank you. I have Jake Whitaker, and then I'm going to call on the committee. Jake?
Thank you, Madam Chair. To Delegate Krebs's point, we're happy to consider study language for the outcomes. But to your original point, I think the purpose of this program was to lower rates as well as increase or decrease the uninsured number. So I think we've achieved that objective, and that's the primary objective of the program. But to Delegate Krebs's point, I think we're happy to consider study language to that effect.
I think that we are beginning to look at a broad-based study that we could implement in next year. And I'm already thinking about what that language looks like. But if we want this bill to move forward, I'm hoping not to complicate it any further.
Great.
Matt Celentano? Nope, you're on mute.
Had to do it once. I won't belabor this, but just for some folks, the primary purpose of this program was not to lower premiums. It was to stabilize the market so the individual market did not implode. That is the whole reason we've done this. The market is now fairly stable and seeing dramatic reductions still in premiums. And if we're going to continue to pump billions of dollars into the market, we're not going to see premiums go up. But the question has to be for this policymaking committee, is that what we're committed to? Never having premiums ever rise in the individual market again? Because if that's the course we're going to take, it's going to continue to impact other markets. This is a tax on one segment of the marketplace for another. And that's where I'll stop. Thank you.
Thank you. Is there anyone who would like to move the amendments?
Nope.
Move the amendment, Madam Chair.
Is there a second?
Second.
Okay, the amendments have been moved and seconded. I will, with caution, say, is there any discussion of the amendments? Seeing none.
Move unfavorable.
Okay, no, I do see Delegate Krebs.
And I'm sorry, Madam Chair, we've been talking about this for so long. Can you just briefly remind me what the amendments do? I know what the bill does, but what do the amendments make it better?
What the amendments do are sort of refund the dental and vision standalone programs because they don't benefit from it, but we needed to keep them in. And then we have study language. We cut some of the study language out, the broad-based study language, and left in language that speaks specifically to the reinsurance program and how it works and what its impact is.
So we're going to do the amendments separately?
Do we need to do them separately?
On the dental amendment, is that an amendment that was supported by the carriers and Kaiser? Is that an amendment that was supported by them or not? I can't remember.
I'm going to look to Matt.
With support.
This is not, Delegate Krebs, thanks for the question. This is not the original way that we looked to accomplish the goal, but with discussions with leadership, I think we're comfortable with this way forward. So yes, is the long answer to your question, sorry.
I mean, if you want to do the amendments together, I'm for the first amendment, I'm against the second amendment because it's not broad enough, but however you want to do it.
Okay, Delegate Kerr, do you want to move the First Amendment?
This
I
is
move the
a
First
little
Amendment.
complicated right now, though, because
I'm sorry.
they're not actually broken up that way in the document. So, so if you want to move, say, 6-105.3, like, I don't know how you want to do it, but
Madam Chair, let me just suggest,
31-107 and then do,
I'm just going to vote against the amendment as a blanket amendment in the interest of time. I don't see any real benefit.
That's fine. That's fine with me.
Okay. So
My
let's leave it
motion,
as,
my motion stands then.
okay, thank you, Delegate Kerr. Those in favor of the amendment say aye. Those opposed, please raise your hand.
aye.
Okay, so I see Delegate Kipke, Krebs, Saab, Morgan. Is that correct? Okay. All right, so the amendments have been accepted. Do I have a motion on the bill?
Move
Good,
the bill.
Delegate Sample uses.
I also, he's voting. Okay.
And you're voting in support of, we just did the amendments, Delegate Sample Hughes. We have the bill on the floor as amended. Do I have a motion on the bill as amended?
Move the bill as amended.
Thank you, Delegate.
Second.
I have a second. Any further discussion on this bill as amended? Okay, seeing none. Those in favor, please say aye. Those opposed, raise your hands, please. Okay, and it's the same four. Okay. All right. All right, we will move House Bill 413 to the whole committee. Thank you all for your rich discussion and participation on this bill. We are going to move to House Bill 1148. 1148 is health insurance two-sided incentive arrangements and capitated payments authorization. Lisa, you want to tell us what it does?
So House Bill 1148 authorizes a carrier to enter into a two-sided incentive arrangement with an eligible provider and specifies what is permitted, prohibited, and required under a bonus or other incentive-based compensation program or two-sided incentive arrangement. The bill also provides that a healthcare practitioner or set of healthcare practitioners that accepts capitated payments but performs no other acts considered acts of insurance business is not considered to be doing an insurance business in the state. There are amendments that start on page 6 of the packet. The amendments strike incorrect references to eligible provider and alter the prohibition that a carrier may not reduce a fee schedule solely because a healthcare practitioner does not participate in the carrier's bonus or other incentive-based compensation or two-sided incentive arrangement program by removing the solely qualification. Then they clarify that the provisions regarding capitated payments applies to plans other than group plans. And that was a technical amendment that MIA requested. Starting on page 7 of your amendments are some amendments from Delegate Kipke. And these amendments prohibit a carrier from reducing a fee schedule wholly or in part because a healthcare practitioner or a set of healthcare practitioners does not participate in a two-sided arrangement, or wholly or in part because of the practitioner's performance. They also provide that a two-sided arrangement may not be the sole opportunity for increases in reimbursement.
Okay, questions, comments? Delegate Krebs.
I didn't have my, I forgot to put my hand down, sorry.
Oh, okay. Delegate Morgan.
So I know that we've been working on this bill for a couple weeks now, and I know there's been a lot of talk amongst the advocates of it and they were working something out with these amendments. Where are we at with that?
So I am going to let, let's see. My understanding is that when we take solely out of the first part of the fee, prohibiting discrimination against a group because they're not participating, that meets the needs of those who were struggling with that issue. So MedChi is on board with that, is what I've heard.
So does MedChi now supports the bill?
That, Jean, I'm going to look at you.
Yeah, so there are 3 amendments, and I believe that Care First, I'm not sure about the league, but Care First, I believe, has agreed to them. The first is what Delegate Cullison, the most very important, is removing solely. We obviously had asked to go further. Care First wanted solely, we wanted more. I think someone from the committee recommended just removing solely, which removed the adverb and solved that problem. That was the first amendment. The second amendment is the Kipke amendment, which was read by Lisa a second ago, which actually, in fairness to Care First, they had agreed to that before the bill got put in, but it didn't make it into the draft because of the timing of the negotiations. And then the third item is just an amendment, a minor amendment to the study, which I'm not sure that language was read, so I don't know if that's an issue. But those 3 amendments resolve the physician issues, and then we're okay, and we're good with the bill.
We need, Jean, I need to be clear. On page 7, Delegate Kipke's, that's reinstating the wholly or in part, which is in conflict with the solely.
Yeah.
So that part, so you're okay taking that out, but what you want to keep is number 6, participation in a two-sided arrangement. So Delegate Morgan, if we take out solely, do not accept 5 Roman numeral 1, Roman numeral 2 of Delegate Kipke's amendment, but accept number 6 of Delegate Kipke's amendment. I believe that brings MedChi completely on board.
And then there's the minor study change.
Right, the study language.
Okay, awesome. Thank you.
Okay. Delegate Saab.
Thank you, Madam Chairman. So yeah, I guess I'm just to piggyback on that. So the amendment 6 basically said that there is, I know there were talks during committee hearing or about having a floor, or I think that was one of the issues that MedChi was having with it. Does this resolve that when it says that the eligible to receive any of reimbursement? Does that solve the problem that MedChi was bringing up?
Gene?
Well, it's not exactly perfect, but if you combine that protection, which would allow, which says clearly that if they lower the fees based on entering into value-based payment, now the physician would have the remedy of being able to file a complaint at the MIA. So it's not as good as, is what happens in Medicaid, where you're guaranteed the fee schedule, but it's more than what we had when we started. And then when you combine that with the fact that the other portions of the bill have the 10% cap on risk, it does get us there. So while it's not exactly perfect, we can live with it because it creates protections and checks and balances for physicians and patients.
Well, good job. Thank you.
Can I just add something real quick? Because I want everybody to be clear that the study language is actually not in what was distributed. I can read it so you know what it is. But yeah, that was not part of the amendments. So adding to the study language on pages 14 and 15, the Healthcare Commission shall report the impact of two-sided incentive arrangements on the fee schedules of healthcare practitioners included in the target budget that are not eligible providers. So we can adopt that, but I just wanted, to make sure it was publicly known what it is, since it's not in the written amendments.
Okay. Thank you, Lisa. Thanks for clarifying that. Dan Doherty.
Thank you, Madam Chair. Dan Doherty here on behalf of the Maryland State Dental Association. We submitted written testimony. We were not part of this because the negotiations during the interim after the bills last year were withdrawn were focused solely on physicians. If we had known it was going to go back to encompassing all healthcare providers, we would have been involved and objected, because dentistry isn't covered under major medical. Dental insurance is very different. And we don't know where this bill would put us under the current type of insurance. And we really feel dentistry should be exempted from the bill.
So Dan, you understand though that it is entirely voluntary. There's nothing about the bill that would require, and in fact, for the most part, and I'm going to look to Debbie to correct me if I'm wrong, or Brian, actually, he's going to correct me if I'm wrong. For the most part, it's not an ideal situation for a single practitioner. So if most dentists are single practitioners, they will not opt into this kind of arrangement. I mean, if you have a group of dentists who are working together, then they may want to. But again, it is totally voluntary.
We do have group practices.
Mm-hmm.
My concern is, again, the protections that are in the bill. As Jean said, they're not perfect. Well, they seem a lot less perfect for dentists than they do for the physicians. And I don't know why it does anybody any good to include us in the first place.
I would suggest to you that one of your groups may actually want to try it. Maybe not, but you know, at least they have the option of doing it if they'd like to. And Debbie, tell me, if a group were to try it and it didn't work for them, they can get out of it, right?
That's correct. So this is 100% voluntary. 100%. The contracts say that either party can get out of the contract. It actually, you know, there's no impact that way. Dan, I assure you that this isn't intended to apply, as you heard Delegate Cullison say, to individual practitioners. They're not even allowed under the bill to be part of these voluntary arrangements. But if there's a group of practitioners who are interested and it makes sense from both parties, then there's always that possibility. And that's what we've been saying all along, is that it may work for some and it may not work for others. And that's why it's completely voluntary for whoever thinks it's appropriate for them. And no one will be forced into any of these arrangements. By law, it says we cannot.
Okay. Dan, does that help?
Says it.
Well, I'd feel a lot better if the provisions about not discriminating because someone refuses was a clear statement. Any group may decline to participate with no negative ramifications from the insurer. And I don't think
we believe it says that.
I mean, I looked at the amendments and they're getting close, but I don't think they're really there.
I don't know if the commissioner is still here. I don't see her on screen, but in my conversations with the commissioner, I asked, you see her? Oh, Commissioner, can you talk to us about what happens when a practitioner makes a complaint relative to, you know, a concern that their fee schedule may have been reduced because they're not participating?
Oh, absolutely. And I have Associate Commissioner David Cooney on the line as well. And our Office of the Attorney General, our Principal Counsel, Van Dorsey, is here to address any of these questions. But we read the bill the way that Ms. Revkin just described it, is that there's an absolute bar that cannot be a basis. And so if we were to investigate and find out that that was the basis, then that action would be reversed and there would be penalties that would apply.
Okay. Is that better, Dan?
I don't know whether it's better. I understand what they're saying. I can't say I totally agree, but I also see the direction the committee is going. So I've had my say. I don't think I can add anything more.
Thank you. Thank you. Deb Rifkin, your hand is still up if you.
There we go. Thank you. I just wanted to reiterate my appreciation for all the hard work that everybody's put into this bill. And thank you, Jean, for working this through. And just want everybody to hear from our point of view at Care First that with the amendments that Jean described, which was coming up with a compromise on, I call them the bookends. The bookends are the protections for providers so that a carrier cannot reduce a fee schedule for the reason that a provider chose not to join a value-based care arrangement. And then the one that Jean just described that's in Delegate Kipke's amendment that said participating in a two-sided arrangement isn't the only way that you could ever get increases. So we can't reduce and you have opportunities to get increases. So that's why I call them bookend protections. With those two provisions, and we're willing to accept the amendment on the study as well. I think you have at least all the parties that have been talking about this for the past year are willing to support the bill, and it's a great compromise, and we appreciate everybody's work on this.
Okay, any other comments, questions on the bill? So, Dan, you raise.
I couldn't find my little yellow hand.
I was going to say, you know how to raise your hand. Dan Shattuck.
I just wanted also to say thank you, and then also just trying to follow this without having it in writing, just to make sure that will there be an opportunity to see this language? Because I know that there was like a new number 5, and we've coupled that with Delegate Kipke's number 6, and just want to make sure that we have everything clear, and that it sounds like, as Debbie described it, that this does kind of capture our concerns, that, you know, those bookends will make it clear that the non-participating providers in those models won't be somehow swept into and held accountable for them. So I think that's what we're looking for.
We'll thank you, Dan, for the question and for working with us on this. We will send out all the information in the next day or two before the committee votes on Friday, because that's when the committee will vote on it. So you'll have everything, but I'm going to review the amendments before I ask for a motion. Jean?
Just really quickly, I wanted to thank Dana and Lisa Simpson for all their hard work too. Dana's done a lot on our side, and all the folks working on the physician side to get everybody together, but Lisa's also been very helpful in getting us information, and we don't thank the staff at your committee enough for all the good work they do.
None of us thank them enough. So you're not alone. They are terrific. Delegate Saab.
Thank you, Delegate Carlson. Can you do you mind just re-explaining your amendment on?
Okay. So
you know, talk about behavioral health. I'm trying to figure out the.
Right. So what we did when you got the original bill, it said that a carrier could not reduce a fee schedule based solely on non-participation in a value-based model. And solely was a struggle for folks. And so what we did was we took the word solely out, knowing that like 2 paragraphs below, it says if there is that a practitioner can file a complaint with the MIA, and one of the things they'll look for is, why the fee schedule was changed. And
no, I'm talking about the first amendment. I know you have like 3.
Oh.
I'm sorry. It was the one that including a network of behavioral health program, behavioral health care program.
It's just making sure, specifying that the behavioral health care programs can participate in the two sides.
Okay. All right.
Yeah.
Thank you.
Oh yeah, I'll go back to the I was looking at the
I think that's Delegate Young.
Like there is a pretty significant for that. But it just says state effect.
Delegate, can you mute yourself, please? Thank you. Thank you. I think Delegate Collison froze. Anyway,
she's having a computer issue. She'll be right back in just a second. Sorry about that.
Sounds like Delegate Saab is in charge now.
I wasn't trying to run the meeting. Well, I'll give it back to you, Delegate Kelly. You're
No, you go for it. It's
you're
your
the
moment.
senior.
I don't know how I got unmuted.
So I guess we have to move the amendments separately, or we move them all at the same time, vote individually.
I got the impression that Delegate Collison was going to just walk through them again, all verbally, and let everybody vote that way.
I think Delegate Collison is back but muted.
So I didn't start off with my little, please forgive us for our technological issues. I usually get a lot more warning when the battery on the computer is going to die. So I apologize. Been that kind of day. Yes, I wanted to walk through the amendments, and then if you want me to pull out an amendment and vote on it separately, we can do that, but let's go through them first and try to do them as a whole. So the first one is the first substantive one, there's some that takes out eligible provider. But the first substantive one is to include behavioral health care programs. And so that's the first one that's critical. The next one is the removal of the word solely from the fact that there's not, that you can't base a fee reduction based on non-participation. The next one is that the participation in the two-sided arrangement is not the only or sole opportunity to have a fee increase. So in other words, you don't have to join to get a fee increase. And then the study language says we're going to actively look at the impact of this program on, and Delegate Krebs, you'll be happy that we'll be looking at patient outcomes on this for sure, as well as on the fees, what it does to fees for practitioners. So those, Lisa, did I miss any? Okay, so those are the amendments. Are there any that anyone's uncomfortable with and wants to discuss further? Okay.
Move the amendment.
Thank you, Delegate Saab. I've got a motion. Do I have a second?
Second.
Okay, I got a second. Any further discussion on the amendments? Okay, seeing none. Those in favor.
Madam Chair, Madam
I'm
Chair,
missing.
sorry, I think you forgot to include the amendment from the Insurance Administration in your discussion, which is your amendment 3 in your vote. I apologize for interrupting.
And remind me what that does?
It's a technical amendment.
Yeah.
It's a technical amendment to ensure that group plans and also individual plans are included. So the way it was drafted, it didn't look that way. So the commissioner requested that amendment just to make sure it was extremely, clear what was happening, but there's nothing substantive about it.
Okay. Thank you, Debbie. Thanks.
Is Delegate Collison frozen again?
Yeah, I think she forgot, she plugged in one side,
Okay.
but she forgot to plug it in the wall.
Okay, all right, we'll wait for her.
It's coming back. Hold on.
Okay. It won't happen again. We have the bill as amended is on the table. Am I correct in that, Lisa?
I
Yeah.
moved the technical amendment. Do we need to move the technical amendment?
It's all part of the amendments, I think.
Okay.
Yeah. But thank you, Delegate. So we have the motion on the bill. It's been seconded. Any further discussion on the bill? Seeing none. Those in favor of 1148, favorable report, please say aye. Those opposed, please raise your participant hand. Okay, seeing none, it passes unanimously. Thank you all. And I too want to add my thanks to all of the folks who worked on this bill. It's a tremendous amount of work over the intercession. And I think we have a really good product, and I think it's exciting. It'll be exciting to watch it unfold. So thank you for that. All right, so we are going to move to actually I'm gonna go to change the order a little bit because Delegate Beitzel is here, and I'm going to look at HB 1111, because I know Delegate Bandari, who would have been next, has to be here anyway, but Delegate Beitzel can be excused if once we talk about his bill. So Lisa, prescription drug monitoring program, prescriber of opioids notification requirement. Tell us what it does, please.
This bill requires a prescriber who prescribes or dispenses an opioid dosage of 50 morphine milligram equivalents or more to notify the prescription drug monitoring program as to whether the patient has received education on the risks associated with opioid use, is aware that an opioid overdose reversal drug is available, and was prescribed or dispensed an opioid overdose reversal drug. A prescriber may not be required to make this notification more than once for each patient.
Okay. Delegate Beitzel, would you like to speak to your bill?
Yes, I would, Madam Chair. Really, the real intent of this bill is to make sure that a prescriber is giving the patient, I might clear the patient, education on what the impacts of the opiate drugs that they're prescribing can do to them. And I've outlined, we didn't have that much time in the bill hearing, and I wasn't able to present the bill, but my staff guy did a great job. But the concern is that prescribers are not seriously taking acknowledging that these opiate drugs are causing severe overdose and addiction problems. And of course, I've had, in my own family, a case where the prescription drugs has caused extreme hardship and problems. But just every family, I think, in the country knows someone that this is the case. And at one point in time, when I was still on HGO many moons ago, and I see Sue, Delegate Krebs, the only one that I see on here that was on HGO when I was there. But at that time, we were talking about like up to 60% of the people that are addicted to opiates were addicted because the prescribers were giving the drugs. And I'm really concerned that the people that are prescribing these aren't taking it serious enough to make sure that the patients that they prescribe it to knows what the consequences are if when they take these drugs, if they don't use them in accordance with the way they're to be taken. And even beyond that, when they are taken the way they're prescribed, the people get addicted. And once they're addicted, the outcomes are worse than maybe the reasons that they were going to get medical attention in the first place. That's really what my concern. And this maybe third time that I've offered this, and would really request that Subcommittee gives favorable consideration to this bill.
So let me ask for questions from the committee or comments from some of the advocates. Delegate Saab.
Thank you, Madam Chairman. And thank you, Delegate, for this bill. So is this only specific to morphine only? Is it just 50 milligrams of morphine and
No,
nothing
this
else?
this is like Oxycontin, hydrocodone. At least that this is the opiate drugs that prescribed opiates that painkiller medication.
But the bill specifically says dosage of 50 morphine milligram equivalent. So is that what you're saying? So anything that's equivalent to that has to be reported, and the provider has to educate the patient and report it to the PDMP?
Right. That's I was hearing a hard time hearing you, that you come and going. So would you ask me the question again, please?
Sure. I'm just saying, so anytime a prescriber prescribes 50 milligrams of morphine or equivalent, which could be all the other ones, they have to upload, notify the prescription drug monitor program that they have prescribed.
Yeah. I think if you don't mind, I think Kristen is on here. Kristen, can you address that question?
Kristen?
Hello, hi, Delegate Saab. To answer your question, it's the one-time prescription. Just that's why the checkbox is there, just because every time you don't feel like you have to educate the person. If a doctor or a prescriber tells them one time, you expect that to be sufficient, as long as that conversation is had and that there is a record that conversation is had, that they have been educated on the risks, the benefits, dangers, and that they have been offered the co-prescription and educated on the co-prescription of naloxone. Then it doesn't need to be happening every single time they are prescribed an opioid going forward.
Right,
You
but
don't want to make it burdensome on the prescriber.
I thought we already do that. Like when we prescribe medicine, and I guess there's a fine line between us trying to legislate medicine on how the doctors, because I think the doctors already do. And
well,
but are we legislating medicine with this bill? Because specifically it said 50. Why not 20 or 50 or 80? Are we getting a little too prescriptive?
This specific number actually falls in line with the CDC guidelines. This is considered the higher dose opioids, which is why the 50 MMEs, this goes along with what 12 states have already passed for co-prescription and for education. So this is typically the trigger of what the CDC is. And as far as what the state has already done, while we do have it stated that we should be doing it, we know that prescribers are not doing it. As we heard in Delegate Beitzel's testimony last week, what he was suggested to do by his prescriber, as opposed to being educated on his prescription, he was suggested that he could sell them if he didn't use them. So this is,
Okay, thank you. I'm sorry, Mention. I just want to follow up on that. So it's already in law, but since they're not following it, we have to do it again so they can follow it because they're not following it. I'm sorry, I'm just trying to figure out what am I missing here.
Well, this is like, I gave the example. I went to a dentist and I had implants, and the dentist handed me a prescription of hydrocodone. I don't know how many milligrams it was, but he handed me a prescription of hydrocodone. Mm-hmm. I look, and because of my familiarity with problems associated with opiates, I asked him, "What's he giving me this prescription for?" And it was like, well, if you don't want it, you don't have to take it. And then I had rotator cuff surgery, and the doctor gave me OxyContin, and I go to the pharmacist to get it filled, but I didn't look at it. And when I went to the pharmacist to get it filled, they gave me the drug. So I get home and I'm looking at it, and the doctor never said anything at all about advising me that there are negative consequences of taking this drug. And really what we're trying to get at this bill here is to make it really plain that any physician or prescriber that prescribes this ought to tell the patient what it is that he's prescribing for them and what it can do to them. And so they can make the decision and know what's going on. And we know how many people are addicted to become drug addicts. We know the cost to society. I know my own family. My son ends up in jail. I don't know how many times he's addicted. We went through all kinds of rehab clinics and everything else. And we had no idea that he was getting this drug, and he had no idea what it would do to him if he was addicted. And what we're trying to do is, and if you look at the drug problem and what's going on in this country, you should realize that there needs to be some more attention, at least some awareness that when somebody gets prescribed these things, what it can do to them.
No, I appreciate that, and I'm totally with you with the intent of the bill. I'm just trying to figure out. I thought we already have it in law now that people have to report. But thank you, I appreciate it.
Delegate Krebs.
Thank you. Questions for Steve Wise. Steve, I know I see your testimony and some of the stuff you say is duplicative, but in the spirit of what's trying to be accomplished, obviously the things that we're asking some doctors to do is not happening with regard to letting people know. I think all of us have stories with dentists and doctors about not informing them appropriately of maybe step, I don't call it step therapy, step medication. So are there any parts of this bill or pieces that we can reignite the medical community and the dental community about the hazards and informing people about these? Because I think it's a real problem. I think it's getting better. But if this bill isn't the correct place and there's different parts of the bill, what are the solutions that we can do to ensure that this is happening every single time a prescription is given to somebody like this?
So I appreciate your question, and I appreciate Delegate Beitzel's comments. But I'll go back to what Delegate Saab was saying initially, which is you can enact as many statutes as you want, but the fact is everything that's been talked about is already covered by existing law. So it's a question of enforcement. And I'll point specifically whether it was a dentist or physician who said what to do with the leftover opioids. I mean, that person should be sent straight to their disciplinary board and have their license at least suspended and probably revoked if they were told to sell it on the street, which I think was the testimony at the hearing. But whether it's that egregious or not, the issue is one at this point of enforcement and making sure the education's being done. I just don't see where enacting another law is going to change behavior. That is a function of education and enforcement.
And you just mentioned education too, and that's part of MedChi's and Board of Physicians' role and all the providers. And I'm hoping that's happening because, I think there's still instances of this happening out there. So short of trying to do something new, how do we get compliance? And that's just a rhetorical question for you.
No, and if I can respond to that just quickly, I mean, the other thing you mentioned, you had read our testimony, we mentioned it in there. The General Assembly took the rare step of mandating 2 hours of education for prescribers on this subject. And that is something that I don't know that you've done in any other subject matter area for prescribers.
Thank you. Thank you, Steve. Delegate Young.
Thank you, Madam Chair. I wanted to refresh the committee's memory because I had a bill that passed a couple of years ago that did pretty much what this bill is asking for. I can't remember the bill number or the year, but I do remember Senator Klossmeyer was my cross file, and I remember the bill well because it passed in the Senate 20 minutes before sine die. So I'll never forget that. But basically what the bill said is that if a prescriber was going to prescribe an opioid-based treatment, that prescriber must have a conversation with the patient telling them what dangers or side effects there might be. And they had to inform them of other alternatives, like, for example, extra strength Tylenol. So I'll just reiterate what was just said before you, that, you know, passing duplicative legislation is not the challenge. It's figuring out a way to enforce what we already have in statute.
So before I go back to Kristen, I'm going to suggest something. And I don't know that it's going to make it through the entire process, but the subcommittee passed a bill, and I think the committee passed a bill that gave the authority of the Board of Physicians to monitor the prescriptions of opioids by physicians. Am I right, Delegate Kelly? Okay. Is there a way for us to, I know that bill is gone, but at least speak with the Board of Physicians about the intent of this bill, and that they can fold it into their investigations as they go forward? Delegate Kelly, do you have any thoughts on that?
Yeah, I am absolutely happy to talk to the Board of Physicians about that. I think that's a really great idea. I think the members of this committee who were also serve on the Health Occupations Committee know that we had multiple weeks of conversation about that process and making sure that the Board of Physicians is, I mean, their intention, of course, is always to do the best job, but that they're open to any feedback or ideas for ways they can do a better job. So I think they would be very receptive to that.
And I think, thank you, Delegate Kelly. And I think really what we're asking them to do is to make sure that they are following the law that's already been passed, where they are being very clear about the potential side effects and harm that these particular drugs might cause. So if we can fold that in. So I'm going to take Kristen, and then we'll try to wrap this one up.
I'll be quick. Yeah, and obviously, you know, Delegate Young, your legislation is great, and this serves as just kind of something to bolster that, because, you know, as you say, you would hope, and we don't think that prescribers or physicians or those that are dispensing the medication are doing any of these things intentionally. Just the hope of putting that checkbox in the PDMP just serves as that final reminder, did this conversation happen? And when you go down the line and you see, you know, when that final person just, you know, hands that bag off at the pharmacy, and they see, because, you know, it's pretty much even the pharmacists that are the ones that are really in it. So even if it's something that needs to be changed to say just even the dispenser, not even the physician, but if it's even just the pharmacist pulling that patient aside saying, hey, just so you know, A, B, C, D, and E, just checking that box. It's just making sure that there is oversight to, you know, what you've done, just to make sure that that's happening. And that's why it's so important. And I also think, you know, the side piece of that is also the offering of and the education of the overdose antidote, just because, you know, with everything going on, especially now that we have a surging opioid crisis and prescription pills are on the rise again of causing those, just having that as part of it, that's also kind of the part two of it. So that is just something I kind of want to tack on to that.
Thank you.
Thank you. I appreciate that. I think what I'm hearing is that there are other ways to handle this, that we probably don't need a bill at this time. And I would ask that we move to the next bill, if that's okay.
Thank you, Madam Chair, for your
And
consideration.
thank you for bringing us the bill, delegates. And you know, I just want you to know, we did hear it, and we understand the need, and we will follow up, I know, with the Board of Physicians to let them know that this is a concern that's been raised, and that, you know, that there are laws on the books, and we need to make sure that people are following them.
Thank you.
Okay. Thank you. Now I would like to go to House Bill 1219, and that's Delegate Bandari. And I am looking for my There it is. This is pharmacist status as healthcare providers and reimbursement. Lisa, you want to talk to us about what it does?
This bill requires individual, group, or blanket health insurance policies and contracts delivered or issued for delivery in the state by insurers, nonprofit health service plans, and health maintenance organizations, as well as Medicaid and the Maryland Children's Health Program to provide reimbursement parity for pharmacists. By January 1st, 2023, MDH must obtain any necessary waivers to implement reimbursement parity for pharmacists for Medicaid and the Maryland Children's Health Program. The bill alters the definition of healthcare provider to include a pharmacist and provisions of law regarding healthcare malpractice claims, maintenance, and destruction of medical records, and HIV testing. If a pharmacy is subject to these provisions and the malpractice claims against a pharmacist, they're subject to the Healthcare Alternative Dispute Resolution Office. And there are amendments on page 8. The First Amendment is technical. The Second Amendment strikes language. Sorry about that. Strikes language related to medical malpractice insurance. Amendment number 3 specifies the scope of practice of the pharmacist. Amendment number 4 strikes language related to HIV testing. Amendment number 5 clarifies that the provisions apply to coverage and reimbursement, and Amendment 6 moves the enactment date to January 1st, 2023. And I know that the carriers and Aaliyah were working on some additional language.
Okay. This is Delegate Bhandari. Delegate Bhandari, you want to speak to your bill? Delegate Bhandari. Is he still here?
I don't see him.
Oh, I don't either.
No, I don't see him.
Okay, so he's not here. So is Aaliyah Horton here? I don't see her either.
No.
Okay. All right, we may have to just hold this one until we can get the important parties here. Okay. All right, let's hold 1219.
Steve has his hand up. Steve Wise, I don't know if he wanted to.
Okay, Steve.
So that's fine. A hold's fine. I'll make my point when you revisit it. Thank you.
Okay. All right, so we'll hold this one, and I'm going to ask that we try one more bill, and then we'll stop after one more bill. So the next bill would be House Bill 974. This is physical therapy, co-payments, co-insurance, and deductibles. This is Delegate Kipke's, but Lisa, tell us what it does.
This bill prohibits a carrier for each date covered physical therapy services are provided from imposing a co-payment, co-insurance, or deductible for the PT services that is greater than that imposed for a primary care visit under the same plan or contract. And there is an amendment on page 5 that's just a technical amendment that specifies that this has to do with policies and not plans.
Okay. Delegate Kipke, would you like to speak to your bill?
Move the bill. Just kidding.
Yeah, just kidding.
We were surprised by the fiscal note related to the retirement plans that the state subsidizes for state retirees. So I had sent to Lisa some, I don't know, it was earlier today, some language to have this further reviewed. We think that perhaps they might not be looking at some of the savings that would be involved in helping people get back on their feet with their injuries or their the issues for which they're seeking physical therapy. I believe, let me just see if Dan Shattuck, there you are, Dan.
Yes.
Do you want to speak to that, Dan?
Yeah, I think, we've had some good discussion on the bill, and I think everyone on the committee heard the need and the importance for this copay legislation. It is an access issue. It is an issue that we think will yield dividends in the long run in the preventive care that it provides, and both helping the patient recover from an acute injury or maintain their function and mobility and their quality of life in the face of a chronic disease, and we've seen evidence that a non-pharmacological approach to treating pain can offset the reliance on opioids. So I think again, given the surprising fiscal note, we don't want the momentum to end on this. So I know Delegate Kipke and I have talked about looking at a study, and we're wondering if we could work on some language to really convert this into that study. And I think that was what the opponents were suggesting as well, that this might be something worth looking at. They clearly seem to support PT and the other rehabilitative providers and the benefits that they provide to patients. So we wanted to see about amending it and working it more towards a study.
I'd be happy to give you another week to work on that if you'd like, and come back next Tuesday with some proposed language. Of course, I'm going to have to be extremely nice to Mr. Ben Steffen again. So,
catch some roses or chocolates.
Right. I'll do what I can. Okay, then if you wouldn't mind, work on that. And thank you, Delegate Kipke. Thank you, Dan, for being willing to do that. So it is 6 o'clock, and I know that some members of MIA and the vice chair and I are meeting on another bill. So I'm gonna say that this committee is finished for the day. And when we meet next Tuesday, we'll take up the two bills that we three bills that we're holding, and including this last one, and then any that we see and in hearings on Thursday afternoon.
Madam Chairman?
Yes, Delegate Saab.
Right. I have my hand real quick, and I did have a quick question to Dan, and it would be just 10-second question.
Sure.
So is the study that you're thinking, is it going to only include physical therapy, or is it, because I think it's a great bill and obviously it's an access issue, but would it be including other professions besides physical therapy?
I want to reach out. I know that the Kairos had expressed interest in amending themselves onto this bill. So if we can look at that spectrum of rehabilitation providers, it might be a worthwhile.
Thank you.
Look, yes.
Excellent. Thank you. Thank you, Madam Chairman.
Thank you, Delegate Saab. Delegate Krebs.
Thank you. And also, there's been a lot of studies already out there about avoidance of surgery, which then avoids opioids and just the costs involved. And I know Howard County Hospital last year had a huge article about avoiding surgery. And I thought it was very interesting. So I don't know if things are already out there, because this is not just a net expense. This is avoiding not just about people saving money on going to physical therapy. It's about avoiding surgeries, unnecessary surgeries, avoiding opioid use, and finding alternative ways first before we do other procedures. So I would hope that it'd be broader than what we're just looking at here, what this cost is going to be. And I think there's stuff out there, because the whole medical situation is sort of shifting away from surgery first. And doing alternative medicine, which we never used those words before, but now even the doctors are using that, like whether it be chiropractic or whatever. So hopefully it's comprehensive, and there might be something out there to go off of versus reinventing the wheel.
Okay, thank you. So I think I saw Mr. Shattuck taking notes. So he, we can capture your intent. Are there any other thoughts, comments, questions, concerns? All right, then thank you all very much for your patience today and for your work on these bills. And HGO will be having hearings tomorrow afternoon, currently scheduled for 1:30. We'll see what time they really start. So thank you all. Have a great
1:30, 1:30. I'm rooting for 1:30.
I'm rooting for 1:30 too. Also.
Are you loud and clear?
Right.
Good night.
Good night. Jocelyn?